All right, perfect. I'm Will Abel. I'm a gastroenterology fellow at Carilion Clinic, training under Dr. Yeaton and Dr. Kesar, and we're here to discuss our paper, EUS-directed transduodenal ERCP in the treatment of concomitant gastric outlet obstruction and biliary obstruction. We're also calling it the EDI for short. And Dr. Kesar is the Director of Therapeutic Endoscopy at Carilion Clinic, also the Program Director of Interventional Gastroenterology Fellowship at Carilion Clinic, and he is an Assistant Professor of Medicine at the Virginia Tech Carilion School of Medicine. Dr. Yeaton is the former Program Director and founding Program Director of the Gastroenterology Fellowship at Carilion Clinic, and is also an interventional gastroenterologist. So to start with discussion of our study, Dr. Kesar, could you tell us a little bit about the clinical problem that we addressed in our study?
First of all, thanks, Will, for the introduction. Specifically, we focused on patients here who had concomitant gastric outlet obstruction and biliary obstruction. As you know, in those patients, a traditional ERCP is not feasible. And so we needed to address those patients in the least invasive way, and that's why we chose this procedure. Also, this procedure is specifically designed for patients who have retained biliary metal stents, which we will talk in further questions.
And Dr. Yeaton, can you tell us a little bit more about the specific steps of an EUS-directed transduodenal ERCP and how you go about setting yourself up for success with this really fairly complex and technically involved procedure?
Well, first, it's important to think about the consequences of your interventions and to think of the distant consequences of it. So the ability to place a stent in the bile duct may technically be possible, but then as the evolution of the duodenal obstruction progresses, it may not be possible then to address, remove, or replace the transpapillary biliary stent. So this procedure provides a way to manage, to access, to exchange, to place a transpapillary biliary stent in the setting of duodenal obstruction. So as a consequence, it's very important to place the transgastric duodenal stent in a position that allows easy access to the bile duct, conceptually, much as you would with the Billroth tube.
Dr. Kesar, can you talk a little bit about the patient population that we had in this study? How many patients were involved, and then about how long were we gathering data for in these patients?
Gotcha, yeah. So we have around 9 patients in this study so far over the last almost 2.5 to 3 years. These patients were all deemed to be unresectable surgically, very poor functional status, and so this procedure was done safely with high technical and clinical success, and we've been able to keep them out of hospital in a very functional way.
Dr. Yeaton, which patients do you think would be best to very strongly consider for EDI? And I'm saying EDI, but EUS-directed transduodenal ERCP. Which patients do you think would be best to consider that as a treatment option?
Again, it's difficult to predict the future, but you want to select a patient that you think is going to survive long enough that they'll have to have the transpapillary biliary stent addressed at some point in the future. Or it might be one that already has a stent that you need to be able to address. So that's the thinking about the long-term consequences for the patient. And then, of course, I think we can discuss a little bit about the type of scope that you'll use to go through the transgastric duodenal stent to access the bile duct, whether or not you want to use a forward viewing scope or a typical side viewing endoscope.
And Dr. Kesar, in terms of the actual outcomes in the study, what adverse events occurred actually during our study, and then in particular, what should future endoscopists be on the lookout for in the future?
Yeah, so in our study, there were no major adverse events that had any implication on patient care, and technical success was 100%, and clinical success also 100%. However, obviously the data set is 9 patients, so which is small, so I cannot have a long, much conclusions from long term here. However, important thing that I would like to focus here is a bunch of these patients already had retained biliary metal stents, which made this procedure really important for them because once you have retained biliary metal stents, Axios as a conduit for ERCP is very beneficial because in these patients, choledochoduodenostomy may not be ideal, and a hepatogastrostomy also is pretty challenging due to a lot of pneumobilia and also the size of ducts being very small. So yeah, so that's the specific kind of patient population where this would work the best. And also a point of caution, none of our patients, we did the EUS gastroduodenostomy and went through that to do ERCP on the same visit. The minimum time gap was 8 days, but say if you have to go immediately, in that case, maybe suturing like that you would do in a typical edge procedure would be a good option.
So Dr. Yeaton, what do you think the implications of our observational study are for the broader patient population out there? And in particular, what kind of further investigations do you think need to take place to help us make the next steps in the field?
Yeah, obviously it's a very niche population, so it'd be difficult to accrue a very large population, but I think of it as just an extension of gastrojejunostomy, only in this case you have to pay special attention to place an orientation at the ligament of Treitz with the duodenum to make it a direct access to the duodenum to reach the papilla without complications.
And so to kind of follow up on that question, Dr. Yeaton, we used both in this study. We used both a side viewing scope and a forward viewing scope. How do you feel about both going through the lumen opposing metal stent as a conduit? Which one do you prefer, and what are your thoughts on that?
My particular bias is to always use the duodenoscope. However, it is slightly larger than a therapeutic EGD, and I think that generally speaking, people are more comfortable with an axial view going through the Axios than a side viewing scope. But I think it just depends on the operator's preference. I don't know that it makes a large difference.
Dr. Kesar, any closing remarks?
Yeah, actually, before we that, another important thought here is when some of these patients, in even our patient population, especially those with chronic pancreatitis, they have lived for many years. So nobody clearly knows how often to change the lumen opposing metal stent in these patients, because in our anecdotal experience, sometimes long term their sheath kind of gets damaged, they can get embedded. So Dr. Yeaton, what's your thought on how often would you change the lamps in these patients to prevent those complications?
Yeah, I think generally speaking, we've been leaving them in for as long as possible. Although I think we have plenty of experience with friends that routinely change them annually or some arbitrary interval. I think it's just one of the things that isn't known yet with how to manage long-term use of a metal stent to create a gastroenterostomy.
Fantastic. Well, thank you both so much for your time.
Thanks for all your
Thank you,
help.
Will.
All right.
Thank you.
Thank you.